Okay, so this is going to be the first part, so we'll call it part one of endocrine. And what we're going to cover here is really everything except diabetes mellitus. We're going to talk about Addison's, Cushing, thyroid glands, gland disorders, Graves' disease, those kinds of things. And then we'll stop and do diabetes mellitus as a second section. Okay, so the endocrine. So the endocrine system, this is going to be a brief run through. Endocrine implies release into the blood, and it's releasing hormones. Okay, so that means that's kind of one of the hallmarks of hormones is they're released into the blood, and then they have an effect on whatever cells happen to have a receptor for that particular hormone. So hormones go everywhere in the body, all of the through the blood, through the extracellular fluid, and then they only land or activate cells that have a receptor for them. Okay, so cell will only respond if it has receptors. Yes, upregulation, that means that whatever cell is releasing it will make more. Downregulation means it means that it makes less. So we have negative feedback systems in place that we'll kind of talk about that regulate whether they increase or decrease their production. So one thing that's kind of peculiar, unusual, or unique here is that we have a two-step system, and I'm not entirely sure why. Although if I think about it, I can make up reasons, and I'm sure that there are other people who will hypothesize why it's set up this way. But we have this area in the brain. It's an actual brain region called the hypothalamus, and the hypothalamus is getting signals from other parts of the brain, feedback and information. And so what it does is that it releases what's called a releasing hormone, usually or oftentimes, a releasing hormone to the pituitary. Now it can be, the pituitary is broken up into the anterior and posterior. The only two hormones released from the posterior are really antidiuretic hormone and oxytocin, so which are peptides. But the rest of them are released really from the anterior pituitary. But either way, the hypothalamus sends these releasing hormones to the pituitary, and then the pituitary, which is sort of outside the brain, which is probably one of the reasons why this is a two-step process, and it releases stimulating hormones to activate the actual glands. Okay, so thyroid stimulating hormone will then tell the thyroid gland to start producing thyroid hormone. The adrenal, let's see, oh, this is ADH. So ADH will tell the kidney to start reabsorbing more water. Okay, so that's what's going on with that axis, or the hypothalamic pituitary axis. Okay, which is what this is called. All right, so the hypothalamus tracks and controls, and it's of course getting signals from receptors in the body that are measuring things like temperature, blood osmolality. So there are sensors that say, oh, we've got too much sodium. So somehow that signal gets back to the hypothalamus, and then the hypothalamus can tell you to either stop reabsorbing, or can send out a hormonal signal and say either stop reabsorbing sodium or reabsorb more sodium or reabsorb more water, those kinds of things. So ions, nutrients, there are emotional components that are involved. Some people talk about oxytocin, and oxytocin having, an effect that's emotional. It's the bonding hormone, whatever. Pain, growth and development, and sexual response. So yeah, activation of gonads, ovaries, testes, hormone levels in general. So releases, so the hypothalamus releases what are called tropic hormones to the pituitary, which then the pituitary releases its stimulating hormones, which activate the actual gland. Okay, so all this is controlled through something called negative feedback. There are a couple of examples here. Here's a thyroid hormone, how thyroid hormone is released. So let's say you have a very low level of thyroid hormone in your body, and so that can be detected, or actually the hypothalamus would say we need more thyroid hormone based on other things probably, but it will send a signal. It'll send thyrotropin releasing hormone to the pituitary, and then the pituitary will release thyroid stimulating hormone, which tells the thyroid, it will tell the thyroid gland to start producing more thyroid hormone. And then that thyroid hormone will increase, and that signal will get back to the hypothalamus and the pituitary gland. And the pituitary gland will say, oh, it looks like we have enough. Or the hypothalamus will say, oh, it looks like we have enough. And so it will decrease its production of these releasing and stimulating hormones. Okay, so that's negative feedback. Don't get that confused with positive feedback. Negative feedback is a reversal. Okay, I say this any chance I get because people get it mixed up a lot. So if my thyroid hormone levels are increasing, and then through negative feedback they decrease, that's a reversal. So they went from high to low, or high to normal. We want to keep it as normal as possible. So that's a reversal. But what about if the thyroid hormones are low, and then it reverses and goes back up to normal? That's also negative feedback. Okay. Positive feedback is like if my thyroid levels were low. I can't imagine a case where this would happen, but my thyroid levels were low, and then something caused them to get even lower. Okay, so that happens with like immune responses. You have your T cells are activated. They release cytokines, which cause more T cells to be produced, which increases the signal even more. Okay, so it's kind of positive feedback is more of a snowball effect, and negative feedback is a reversal. And here I have almost the exact same example, but with cortisol. Okay, I'm not going to read through it because it would just be the same thing, just flipping the words to adrenal corticotropin hormone and that kind of thing. Okay, so diseases of the anterior pituitary. Remember, the anterior pituitary is where most of these hormones are released. It's based on capillary rather than neuro, but that's one of the differences. And but the causes of that, so we're interested in diseases. So the causes of hypopituitarism can usually involve, well, it's when the pituitary gland isn't doing its job, obviously. And so pituitary infarction or tissue damage, cell damage to the pituitary, part of it is destroyed somehow, or it just isn't getting enough of a signal. But lots of things can cause that. Hemorrhage, there's something called Sheehan syndrome, which is blood loss during and after childbirth that will then reduce perfusion to lots of areas, but the pituitary gland is affected, and so it's not able to do its job, and so that would be hypopituitarism. So shock in general is also just a decrease in perfusion, and so it can't get the nutrients or the blood supply that it needs. Head trauma, yeah, that's a damage. Infections can do it. Tumors can do it. Anything that can possibly cause damage or decrease in function, because that's what it is. In some cases, it can lead to panhypopituitarism, which is you have the loss of all of these functions. So a lot of all of the hormones that are released by the pituitary are deficient. You would have to supply these through medications to kind of get things as close to normal as you can. Okay, so hyperpituitarism almost always caused by a tumor. Okay, so a benign, slow-growing pituitary adenoma. Remember, adenomas, that's what we refer to with a secretory, when secretory cells are involved. So that's when you have cells that are supposed to, let's say, produce growth hormone, but now you have a tumor, and so it's making a whole lot of these growth hormone secreting cells, and so you have too much growth hormone. Okay, so manifestations can be, really it's going to depend on which hormone, but headache, fatigue, visual changes, that's going to be associated with a tumor. Okay, so the actual tumor is going to cause these things, plus you have the other effects of the actual hormone that's being released. So hyposecretion of neighboring anterior pituitary hormones. So yeah, here in this case that I just happened to randomly pick with growth hormone, yeah, you're producing more growth hormone, but that may decrease your production of, like, let's say, thyroid hormone, okay, or something like that. All right. So let's talk about some of these, and probably this is why I mentioned growth hormone so quickly. It's one of them we're going to cover. But hypersecretion of growth hormones. Let's say you have one of these benign adenomas, these tumors, and it's causing you to produce too much growth hormone. Well, there are a couple of different forms because that can happen at different times. You can form these tumors as children or as adults. If it happens as an adult, it's not going to make you taller. It's just going to increase the size and certain characteristics, the size of your hands and feet, and just it's usually not a good look. So enlarged skull and paranasal air sinuses, broad nose, thick lips, spaced teeth. Okay, so things that you don't necessarily want to have occur: hypertension, cardiomyopathies, diabetes, arthritis. So it's not good. We call that acromegaly. So remember that. Acromegaly is when it happens as an adult. Now, if it happens as a child, then if you're still in a growing phase, then it's going to cause you to grow to be 8 feet tall. Okay. Well, okay, not every time, but it will cause an increase in height and size. So it's called gigantism. Okay. But yeah, gigantism, remember that, is associated with hypersecretion of growth hormone in children and adolescents when they're still in that growing phase. Okay, so there's also, one of the other things that is released from the, in this case, the posterior pituitary, is something called vasopressin or antidiuretic hormone. So we're going to talk about a couple of different I guess, diseases that are associated with antidiuretic hormone release. The first one being something called the syndrome of inappropriate antidiuretic hormone secretion. Very descriptive. You're secreting an inappropriate amount of antidiuretic hormone, and really we're talking about hypersecretion. So we're secreting too much antidiuretic hormone. Antidiuretic hormone in the kidneys is supposed to cause an increase in reabsorption of water. Okay? So if you have an increase in reabsorption of water, or too much of an increase because you're making too much of this antidiuretic hormone, that means that you're pulling water back into your body like all the time. And that's going to cause, well, hypoosmolality. So there's going to be too much water. Your blood pressure is probably going to go up, and you're going to have increased volume, okay, due to increased volume. So one of the other problems with this disease is that it also dilutes the sodium. Okay, so here's sodium that's supposed to be in there at a normal concentration, but then when you add so much water around it, suddenly your sodium is at a really low concentration, not because the sodium left, but just because there's more water in there. So unfortunately, what your body does is it says, oh, there's not enough sodium, so it causes the RAA, the renin-angiotensin-aldosterone system, to turn on, which means that you're going to now start reabsorbing more sodium back into the body, which is going to bring more water with it. Okay? So it's trying to correct, but in a sense, all it's doing is increasing your fluid volume even more. So clinical manifestations related to an enhanced water retention, yes, hyponatremia, and serum hypoosmolality. Okay, so those things kind of make sense. Well, there's another disease called diabetes insipidus. Now, it's not associated with blood glucose levels at all. It just has the commonality that, just with like diabetes mellitus or type 1, type 2, you have an increase in thirst and you have an increase in urine volume. Okay, so you produce more urine, which makes you thirsty. Just in the case of diabetes insipidus, you don't find glucose in the urine. Okay, so it has no effect on glucose as with type 1 or type 2, but it's related to antidiuretic hormone. Only in this case, and you might be able to guess, instead of producing too much, having too much antidiuretic hormone, there's not enough of the activation. Okay, so so the let's see. So that can be either neurogenic. Okay, so that neurogenic just means that you're not producing enough of the antidiuretic hormone. Okay, so that's what the cause is, and or it can be nephrogenic. So it can either be not a release because it's being released from neurons. So either not enough of the release, or it's being released, but the kidneys are not responding to it. And so we would call that nephro, because nephro refers to kidneys. So nephrogenic. Okay, so either way, you're not producing, or the receptors aren't detecting antidiuretic hormone. And so that means that all of that urine, okay, that was going through those nephrons is not being reabsorbed, and it's leaving. Okay, it's leaving the body as urine, which is going to cause a lot of polyuria, so a lot of urine, polydipsia, increased thirst, and so manifestations related to enhanced water excretion, hypernatremia. Okay, so remember, you have the sodium in your body that's supposed to be at a certain concentration, but if you can't pull the water back in, then it's going to get more and more concentrated, not because necessarily that you're producing more sodium, but it's because you're losing the water. Okay, so partial or total inability to concentrate urine. So you can detect that pretty easily by measuring something called specific gravity. And specific gravity is just water. Specific gravity of water is 1.000, might be 0. Okay, and so when you have particles in it, it might go up to 1.0001 or 1.0004. Okay, so we can monitor that, and when the specific gravity is really low, that means that you're just dumping basically water. Okay, so if you're in fact, all of these are pretty low. So if your specific gravity is low like this, then that could be an indicator that you're, for whatever reason, dumping more water than you should. Okay, and so that's diabetes insipidus. Okay. Okay. All right. So now thyroid. So we'll talk about the thyroid gland. We've already talked about the feedback and the basic mechanism that it works by. So thyroid releasing hormone released by the hypothalamus, thyroid stimulating hormone released by the anterior pituitary, and then the thyroid gland releases the actual thyroid hormones. Okay, they're called T3 and T4. T3 because it has 3 iodine. That's kind of important. Okay, T4 because it has 4 iodine molecules, and that's so essentially what happens is these things are being made. Okay, so if we kind of imagine ourselves here in the thyroid gland. Okay, so we make a precursor molecule called thyroglobulin, and it's just waiting for iodine to show up. And when the iodine shows up, it is, and I'm oversimplifying here, but it gets the point across, is when, so here's this precursor molecule that's being made, and then it gets its iodines, 1, 2, 3 for this one, and then it goes out, and it does its job as a thyroid hormone. Okay, so let's say this one's getting 1, 2, 3, 4, and then it leaves. Okay, now if you don't have enough iodine, then what happens is these precursor molecules just build up and up and up. And that's going to push out on the wall of the thyroid gland, and the thyroid gland is going to get larger. Okay, so we call that a goiter. When the thyroid gland increases in size, we call that a goiter. It's not just caused by iodine. It can be caused by just too much of a signal to produce too much hormone, and so it kind of builds up in there as it's being released, and that can cause a goiter as well. Okay, so the reason this happens though with iodine production is because if you don't have enough iodine, then you're not releasing the thyroid hormones, and so your pituitary gland doesn't know what's going on, and so it just keeps telling you to make more and more and more. Okay, which causes more and more of these. That's almost like positive feedback, sort of, but it's it's trying not to be, but it's releasing more of, or producing more of these precursor molecules, and then that's causing more growth. Okay, and it's trying. All it's doing is it just wants enough actual thyroid hormone out here. Those are iodines on there. Okay, so goiter, iodine deficiency is one of the things that can cause a goiter, which is just an enlarged thyroid, causes incomplete manufacture of T3 and T4, so it's not released fast enough, but TRH and TSH from the hypothalamus and thyroid continue to be released at high rates. Okay, so a couple of diseases associated with, really, we have categories for these, and they make sense. Hyperthyroidism means you're making too much thyroid hormone, or actually it's overstimulation of the thyroid, because it doesn't necessarily mean that you're actually making the hormone, but it means that the thyroid gland is being overstimulated. And I guess really, yeah, I guess really it would have to be the release of thyroid hormone. Because that's what the manifestation is. The manifestation shows what happens when too much thyroid hormone is released. Okay, so it is. It's the overstimulation and the release. So thyroid hormone, thyroid tumors can cause this. No surprise there, really. But the disease that you need to be aware of or know about is something called Graves' disease. And Graves' disease is interesting, to me anyway, because it's autoimmune. So you're making antibodies to the thyroid stimulating hormone receptor. So the receptor, that signal that the pituitary is sending down, is supposed to bind to a receptor, that thyroid releasing hormone, or thyroid stimulating hormone, is supposed to bind to a receptor. Well, you have antibodies that will also bind to that receptor. Now, what's unusual to me about that is usually an antibody will decrease the function of something. It usually kills it, essentially. But in this case, the antibody actually activates that receptor. Okay, so it causes the thyroid gland to continuously produce thyroid hormone. So that's a hyperthyroidism. Okay, so the thyroid gland does a lot of different things. It's always been kind of an intriguing hormone to me because it's hard to really nail down exactly what it's doing, but you can kind of tell. We like to say things like it increases metabolic rate, which it does. So that's going. So the turnover, how quickly you process, you make ATP, burn fat, that kind of thing. So you'll see weight loss, hair loss is also involved. Arrhythmias, so it has an effect on your heart. Bone loss, so it causes resorption of bone, of probably calcium phosphates, or and phosphates from the bone. Heat intolerance. Now that goes back also to the increased metabolic rate. We warm our bodies by increasing our metabolic rate. We burn glucose more quickly, okay, or fats, and so when we burn those things, it creates a small amount of heat. So if you're doing that all the time, and so your body is really struggling to keep a normal body temperature as it is, because these cells are working so hard and sending off heat, that when you go outside on a hot day, it's going to be really rough. Okay, so we call that heat intolerance. You would be less tolerant to heat. Okay, sleep disturbances can happen. Goiter, because you're overstimulating that thyroid gland. Okay, exophthalmos, which is what we see here with the eyes. Okay, so that's an increase in connective tissue. I don't know if it's collagen, but some kind of fibrous tissue around the eyes, behind the eyes, and it causes the eyes to push out. So this person isn't surprised. They're not opening their eyes on purpose. Those are just the eyes sort of popping out from the back. And there are lots of others. Now, hypothyroidism can cause, so here's an autoimmune disease, Hashimoto. Hashimoto's is where the antibodies are attacking the thyroid gland. Okay, so decreasing the function, which makes more sense to me. Thyroidectomy, so if you lose the thyroid or part of the thyroid, and iodine deficiency, which we already mentioned. That's when you aren't producing enough thyroid hormone. So you see a lot of the opposite effects. Weight gain. Okay, so that means if you aren't producing enough thyroid hormone, then that's going to trigger your cells to kind of want to preserve energy, produce more fat, burn less ATP. And so that's associated with the weight gain. So goiter, we already mentioned that, and just kind of pay attention to that. We see goiter on both sides here. In one case, it's overstimulation. The other one is what I just gave the example of with iodine deficiency. If we don't have enough iodine, then that precursor, that thyroglobulin, builds up and causes the thyroid gland to swell. Okay, so that's iodine deficiency. Cold intolerance. So now we've got a situation where your cells aren't able to produce much more heat. Okay, so that means that you then, when you go outside on a cold day, your natural way that your body is warming itself isn't functioning right, and so you have so you're going to be less tolerant to cold. Okay, so reduced heart rate, high cholesterol, and fatigue. You're just kind of tired all the time, less energy. Now, usually hyperthyroidisms can cause, so the most common endocrine malignancy is thyroid carcinoma, and it's often caused by ionizing radiation, and it's treated with thyroidectomy, suppression therapy, or you can just give radioactive iodine. And radioactive iodine tends to collect, in the case of hyperthyroidism, iodine, one of the main places that it will show up is in the thyroid gland. And so if it's radioactive, then what it can do is it can actually destroy tissue in the thyroid, and that can be a treatment for a tumor, however that tumor may have been caused. Okay. So the last thing we're going to talk about is the adrenal gland and the adrenal cortex control and feedback. So there's the corticotropin releasing hormone that's released by the hypothalamus, and then adrenal corticotropic hormone, which is released by the pituitary. Okay, so it's got that axis, that HPA, in this case, adrenal, hypothalamic, pituitary, adrenal axis. And so any of these things, infection, pain, hypoglycemia, sleep, whatever you think can cause stress is going to cause the release of cortisol. Okay, so it's the stress hormone. It's released from the adrenal cortex. Remember, the adrenal cortex, renal refers to kidney, and adrenal means that it's sitting right on top of the kidneys. So that's the adrenal cortex. And then, of course, the adrenal gland has a cortex and a medulla. It just happens to be that cortisol is released from the outer part, so it's released from the adrenal cortex. So it increases blood glucose. So we like to think about the pancreas and glucagon and those kinds of things as controlling blood glucose, but it's important to remember that cortisol increases glucose levels, adrenaline increases glucose, growth hormone increases glucose. So there are a lot of things that increase glucose levels, and cortisol is one of them. The sympathetic nervous system response, sympathetic meaning your fight or flight. So it increases free fatty acids to be used as energy, muscle breakdown. It's trying to, again, figure out a way to make more energy so it can break down muscle. Catabolism, which is breakdown in general, and an increase in plasma proteins, which that's kind of related. Okay, so that's what happens with the release of corticotropin or cortisol. But one of the other things, and this is kind of a problem, is that it suppresses the immune response. Okay, so apparently you want to save your energy for other things when cortisol is being released, and so it will very directly suppress immune and inflammatory types of responses. Okay, so there are a couple of, just like with thyroid, there's overproduction, there's underproduction. Overproduction of cortisol can cause something called Cushing syndrome. Now, Cushing syndrome, remember this as a syndrome, and the fact that it can be any cause, because really we see a lot of Cushing syndrome with people who are on long-term steroid treatments. Okay, so because the steroids, glucocorticoids themselves, when they're given, can cause the same type of reaction. So we see this syndrome, and so fat pads, which they named buffalo hump, thin wrinkled skin, poor wound healing. Remember, because your inflammatory response is shut down. Osteoporosis. You might have some clotting disorders, muscle wasting, weakness. Okay, so that's Cushing syndrome. It's you know, a lot of people who are under constant stress can start to show signs of this. Okay, just because of, you know, psychological stress. Okay, so it can come from anything. Medications like prednisone or pituitary tumors are common. Now, Addison disease is the opposite. Okay, so that's an insufficiency. You're not producing enough cortisol. So we see that cortisol is kind of necessary. So it can be autoimmune, which means that it's being attacked, and that's why the cortex is being attacked. And so that's why you're not producing it, or something is. Tuberculosis can cause it in a lot of third world countries. Usually in more developed countries, it's autoimmune. But you see kind of some of the opposites. You see hypoglycemia. That makes sense. Hyperpigmentation, loss of weight, as opposed to a gain of weight that we saw with Cushing. And then, yeah, and so urinary losses, retention of potassium, which have to do with really, I keep talking about cortisol, and I'll just say this because that's generally what we think of, but it can also affect aldosterone. Okay, so that's why we see retention of potassium and losses of sodium in water. Okay, so that's it. The next part will cover diabetes.